Like
Real,
everything,
so everything in medicine.
in medicine, do we do this? Do we do that? What do I do for my incontinence? Depends. Welcome to Family Med Distilled, another amazing edition. That's right, we're going to talk about dad joke medicine, and we've got amazing topics for you here today as well.
Today, yeah, we're doing a couple of articles from this month's CFP Journal, March 2024. It's actually a little bit light because I've torn out all of the advertising. Desperate for family medicine physicians across the country. But what are we going to talk about, Simon?
Well, we're first going to talk about infections in kids. That kid comes in with a fever and they got a runny nose and a cough, and it's a really valid question. Should we dip their urine? Do they have a UTI?
And then after that, we're going to talk about two different articles. We're going to talk about a topic that will put you to sleep. Insomnia.
Insomnia, exactly. And then there's a second article about insomnia, specifically about the new insomnia medication. My name is Dr. Simon Moore. I'm a family doctor in Vancouver, British Columbia.
And my name is Dr. Paul Dillon. I'm a family doctor in Sechelt, BC.
And we are going to try and cram in as many dad jokes as we possibly can. So definitely, if you come up with some of your own, put them in the comments, because that's what we live for.
Yeah, that's how we build up the
jokes.
database of jokes.
Between the database, between the three of us, we got 5 kids, not like together. We both have our own wives. And so what level is your dad joke ability going to be?
I'm a level 2 dad. I've had the 2 kids.
I got 3 kids, so that makes me level 3 dad joker. But
That means your jokes are actually worse. Is that right? It's like
Yeah,
It's
exactly.
a convoluted inverse relationship between the quality of dad jokes and the groans that you get afterwards.
If you don't like them, don't worry. They're only going to get worse. So let's start with this first really valid article that talks about, do we get urine testing in kids who have a fever? What's your answer?
So it depends. God, I hate that, eh? Like
Just like
real
everything-
everything in medicine.
In medicine, do we do this? Do we do that? What do I do for my incontinence? Depends.
Should I have another kid?
No, please
I
don't.
thought you were going to say it depends.
No, I meant
I'm
your
a
kids.
good dad.
I meant you.
Yeah.
Right? Trying to throw shade at you, not at your actual children. That's over the line. Sorry about that one.
So here we are. So what does it depend on? Depends on age. So what this article, the article is entitled, it's not even a title, it's a sentence. Should you test for urinary tract infection in children with respiratory symptoms?
Runny nose, cough, maybe some shortness of breath. Should we check their pee? Obviously, the parents will be like, what are you doing? We're looking for the cause of their fever. So if they're under 2 months of age, the answer is crystal clear.
Should be done. Yes, younger than 2 months of age, regardless of whether they have respiratory symptoms. Under 2, you're going to do.
You're gonna look at number 2.
Under 2, you're going to
Number 1. No, number 1 is pee.
Number 1 is, yeah.
Number 2, sorry, I always
Do you always
trying to
mix them
remember
up?
this. Yeah.
Front to back, back to front?
Number 3.
Number
Mix
3?
them up. Is that what happens?
Number 3 is what happens when you get really old. Fecal and urinary
Gosh,
incontinence.
okay. Well,
That's
this
a
is about
special-
children, so let's
Yeah.
stay on topic because I don't like where this is going. So how about those kids who are older than 2 months of age?
So they use 2 to 24 months of age, and you should not exclude the diagnosis of UTI based on respiratory symptoms alone.
And it's really interesting when you look at the research. Some of the studies said that a kid with influenza in that age group had 0.5% chance of UTI, and other studies said that it was up to 7.5% chance. So you could be missing UTIs if you say, oh, they got runny nose, they got cough. It's just respiratory infection.
Interesting. And so what could you use? I know there's certain calculators. So, I mean, it took me a while to realize, but this is an online calculator. You don't just have them pee on a calculator.
Oh, gosh. Yeah.
UTI
Calculator.
calc. I mean, that's what it says. UTI calc.
UTI calc reminds me of that amazing kidney stone calculator for urinary calculi. The calc.
Boo. The calc.
So that one's not real,
No.
but UTI calc is absolutely real and really valuable too. I love it because you type in the variables, the age, the status, what the urine shows, and it tells you the % chance of UTI.
You still have to use the little clinical acumen there, but yeah. So there we have it. So under 2, you do test, and then 2 to 24, use something like UTI calc. Don't pee on a calculator.
Yeah. And I always warn patients, when I'm pulling out my phone and I start scrolling and typing in their variables, like sometimes they're looking at me, they're like, what are you doing on your phone? I'm like, I'm using an actual calculator to try and determine your symptoms.
Amazing.
Because otherwise I think I'm just Googling their symptoms.
Okay, so that's it for UTI. So let's turn day into night. Wait, what's on this page? Oh, that's a conveniently placed insomnia treatment article or advert right
For an article,
there.
yeah.
Oh, when day turns to night.
So-
Consider, don't say it.
I love how it's an article for an insomnia drug, and the very next page says, "Don't use insomnia drugs." First line.
That's convenient. Does it actually?
Yeah, exactly.
Oh my God, there's the summary. Don't use drugs.
This article is treatment of chronic insomnia in adults, basically grumpy patients. Like if you are not sleeping,
Yeah.
these are going to be really
Yeah, but
upset.
I mean, it does have social implications. But and so this is specifically insomnia versus like in the summer you're sleeping outside. Outsomnia. It's a little bit easier sometimes to take a nap in a hammock. That's the treatment for outsomnia.
Okay. My personal cause of insomnia is having 3 kids.
Oh, yeah. Chronic parenthood.
I don't think I've slept a full night in a decade.
Wow.
There's constantly somebody up at night for one reason or another.
Oh, yeah.
So I definitely can't take sleeping pills because I got to be awake for their nighttime wake ups.
So kind of the pre-treatment for chronic insomnia is a vasectomy.
Sounds good. So it's not in the article, but that
It's not in
makes
the
sense.
article, but I mean.
Now
yeah.
they talk about the first line treatment is going to be non-pharmacologic options, and they list several.
Yeah, so this is interesting because this is a challenge. Patients will come in and they almost know I'm going to get a pill or I want a pill, but first line treatment is non-pharmacological, and it's sometimes a bit of a challenge in a quick visit to say like, here's what you're actually going to do. So there's biofeedback. What else do they have there? They have just
Stimulus control therapy. You got to control those stimuli.
Oh.
They got multi-component therapy. They got relaxation therapy, biofeedback. But you're right, some folks actually just want a prescription, and so that's why Choosing Wisely Quebec has actually created a tool in English and French, which is a non-pharmacologic prescription pad. It's a non-prescription prescription pad.
Oh, just a pad of paper.
Just a pad.
Just a pad. Why is it Choosing Wisely Quebec?
There's all sorts of different Choosing Wisely's, and I guess in some provinces they choose differently.
Choosing Wisely Quebec, I'd be like, I'll take the poutine. Sounds like the Quebec.
All right.
Quebec.
It's a wise choice.
Wise
But
choice.
the most effective non-pharmacologic treatment, the first line treatment for insomnia, chronic insomnia, we haven't even mentioned yet. What is that?
CBTI.
Yeah, not just CBT. We're talking about CBT specific for insomnia. How do we access that?
So there's online apps for it. There's websites. There's probably some printed handbooks as well.
In the good old fashioned, like hire someone, pay them a crap ton of money, and they therapize you with CBT.
I feel like I do CBTI for my kids. It's like reading a storybook to them.
Okay.
Maybe if you had someone read you a story,
Maybe.
would that work?
Why don't we try it sometime?
Try it.
Give me a call.
You
I'll
should
read.
write a children's book and then read it.
I have written a children's book.
What?
Yes. What a coincidence. I'm
Oh.
glad you brought that up. Thank you.
But hit purchase on Amazon on the link down below.
Yeah.
I feel like we should say
It's currently actually a #1 top seller in a category of children's books about physician parents with
Oh.
hidden clues about developmental milestones and safety risks. Not a big category. I don't know of any
No.
other books in there.
Yeah, that's good then. You actually have the top 2 sellers. I think, in that.
Yeah, because one book is called Daddy's Becoming a Family Doctor, and the other one is called Mommy's Becoming a Family Doctor.
It's brilliant.
I appreciate that. That's
Yeah.
probably the only time you've ever said anything nice to
Yeah.
me. The nicest thing you've ever said to me. Sorry, that's.
I hope nobody's recording this.
So we know that patients want the pills, and so there's a few really key messages about the pills. We've got the insomnia medications, the benzodiazepines. How common are those?
Super common.
1 in 10
Yeah.
65 plus folks are on a benzodiazepine. That's probably way less than it used to be.
Yeah, I think we have seen some movement getting people off these medications. I think key message really is you're not supposed to be on them. When you look at the indications and timelines, like max 14 days for a lot of these. But I've seen them. Patients have been on them forever. It's hard to get them off.
I found that one, I mean, we can talk to the folks about the side effects and the cognition effects and the somnolence, which is shockingly a side effect of,
Ooh.
of
I think
insomnia
what
medicines.
they're referring to is like the somnolence next day.
Yeah,
so
and
the
then
kind
you
of
get
hangover effect.
it can lead to falls, but the one that really convinces people to reconsider their benzos is when I say, this drug increases all-cause mortality.
Oh wow! Yeah.
You're more likely
Yeah.
to die on this medication. It says alcohol or sedatives are involved in 92% of opioid-related deaths. So
Why are you co-prescribing opioids?
sometimes you don't co-prescribe it; they're just getting them somewhere.
So yeah, so increase the risk of falls
Mhm.
without increasing the risk of falling asleep.
The wrong kind of fall.
The wrong kind of falls.
They talk about some of these new drugs, the Orexin antagonists. I found it really unusual that an article that just came out talks about lemborexin, also known as Dayvigo. That's on the market in Canada. They talk about suvorexin, which is approved in Canada but is not being marketed in Canada. And they don't talk about daridorexin, which is also known as Quvec, which is on the market in Canada. So a couple of unusual omissions from this article, I find.
Someone fell asleep at the wheel.
There we go. So before you fall asleep, let's move on to our next article. Before that, a couple great tools, though, we've got to mention. The Sleep Well website puts you to sleep, just like reading Paul's autobiography. And also, deprescribing.org has a great flowchart to help you navigate those conversations with when should you be on an insomnia medication, when should you not, how do we get you off this medication.
Interesting. Okay, so 2 great resources there. Brilliant. So let's move on to the next one, which is those orexin antagonists, the ones that you just talked about, for insomnia. Do they actually work?
They do. Well, depends what you mean by work. Like, if we're going to give somebody suvorexin, which is not available in Canada, lemborexin, which sounds like a car I couldn't afford.
It's expensive, though, on that point. Like
Lamborghini Exins.
It is expensive. $50 a month for 30 tablets. You know what that's going to do? It's going to keep you up at night worrying about your finances.
Yeah, but you can't put a price on sleep, right? So
I think they did.
Yeah, they did.
$50. It's $50 a month. That's the price.
Wow.
Yeah, you got to be willing to pay.
But there's a great rule of threes you came up with. So rule of tens.
Rule of tens.
To help us decide, is this the right medication for a patient? So CBTI has failed. The other non-pharmacologic options have failed. So what do you tell your patient about these new drugs?
So for the new drugs, the evidence isn't great. So you'll get to bed 10 minutes earlier. You'll stay asleep for a total of 20 minutes. So you could say 10 minutes at the beginning, 10 minutes at the end. But then 10% are going to have daytime somnolence the next day.
So, I mean, if you're down on the list of things you've tried and there's nothing better, then your patients are definitely going to want to try this if they can afford it. Does it work in older folks?
So similar efficacy in those over 65.
Yeah, they've specifically studied that. So I find that really, really useful.
And we don't know about abuse yet for these new medications.
How convenient. They didn't actually study the abuse potential of this when they were trying to get approval for it. They didn't ask the patients, are you addicted to this medication? Now, there are really key features here as well about, figure out why else could this patient have trouble sleeping.
Sure, it comes back to the basics. Maybe you've got this kind of flow and you've just going with it and you haven't really gone back to ask those key questions. What's underlying this insomnia? Why can't you sleep?
Mm-hmm. Well, if you've got nothing else left to add, then I'd say let's put this one to bed.
Let's put it to bed. Beautiful. I'm Dr. Paul Dillon.
I'm Dr. Simon Moore, and we will see you next month for Family Med Distilled. That's right, Dad Joke Medicine.